this here is, that's the one on the right forward.
Okay.
It's back. There is a pointer.
Oh, really?
I have it turned on right now.
That's pretty high tech. I don't think we had that the last time.
No, it's new.
New.
Now I can't remember. Oh, here.
That's a pointer.
No, that's the whole thing's on.
On
and
turn it
once
on.
it's on, the pointer's down here, I think.
Okay. That's okay if it doesn't.
Oh, there it is.
There it's open. Oh,
But
it's that button. Okay, the middle.
Right there,
screen.
yeah.
Okay.
So I'll leave it on here. Yeah.
Did you turn the switcher on?
Oh, so
The pointer?
Yeah.
you can switch.
Yeah, I got it on.
You can switch slides on that. How do you change the slides? There's an arrow. There's an arrow on there.
Sorry.
He was just orienting me on.
That's forward, that's backwards.
Backwards. Okay. Perfect.
And then this button up here is the pointer if you need it.
Okay.
Okay. Y'all ready to go? Okay. Hello, good afternoon. Welcome. Welcome everybody. So glad to see you all and so appreciate y'all attending these presentations. I think it's very encouraging for the young doctors who present, and it is to me too, and it's a reminder, I mean, we're out here seeing patients and doing medicine, but getting to do this is kind of a special enhancement. I think it's a good experience for them. First of all, you know what I tell them? They have to put medical terms in lay language where everybody in the room can understand what we're talking about. So if they don't do that, call them on it. I try to. I'll try to remember. Hello. So good to see you all. So today, I think we have a really special group of presenters. You know, one of the great things about this residency program and our being out here in rotation, bringing our residents out here to Butterfield, is we have so many interesting backgrounds in these medical residents, these young doctors. We very forthrightly say we want to get people from Arkansas. If we're not getting some people from Arkansas, we're not doing our job. And if we're not trying to keep everyone, wherever they're from, in Arkansas, we're not doing our job. That's part of the purpose of the education program. But we love also international trainees, and we have a lot of them. This is the first, though, that we have two from the same continent, from Africa, different countries, but I thought it'd be great and that y'all might enjoy just hearing a little bit about their background and their home country and where they're from. I've noticed since in the 4 weeks that they've been here, patients have really enjoyed hearing about their country, and I thought not a bad thing to use a few minutes that way. So I think if they're going to do that, they're going to answer questions if they need to on it. So let me introduce, many of you will know Dr. Mamois Andela. This is the second or third time you've been out here? Third time, I thought so, yeah. That's kind of the maximum. And she is a wonderful young internist who's interested in geriatrics. That was the first words out of her mouth when I met her. So she's such an accomplished physician already and has such a promising career. She's from the country of Cameroon. Anybody been to Cameroon? Can anybody find it on the map? Oh, y'all are in the same boat with me here, so that's why she's going to educate us a little bit. And along with her, the first year resident, we often have an upperclassman like Mamois paired with a first year, which is also sometimes called an intern. You're familiar with that term, of course. Dr. Kingsley Nawuba. I think I got it right. And he teaches me and he reminds me and I get him to correct me. But Nawuba, not Nawabu, You know, he's good natured about when I mispronounce it. So he is from Nigeria, the country of Nigeria, and he's run into several people who have been there and some who've lived there since he's been here, and so that's interesting. But they are speaking on a very common medical problem. Anybody know anything about arthritis? I do. And so they're going to kind of overview the common types of arthritis, and then be open to questions about even the parts of arthritis that they don't cover in the lecture. So, with that introduction, I'll let you guys have the mic. Do you both need one hot at the same time, or are you going to do one at a time?
We'll do one at a time.
Okay. Leave this here.
All right. Good afternoon, everyone. I would like to thank you all for being here. We feel very honored that you took time. The weather is really nice, but you took time to come and listen to what we have to say and ask questions and give us the opportunity to share. Also would like to thank the gentleman who's running our slides today for us for taking time, Nathan, to do that, and for our wonderful nurse, Robin, who's been guiding us throughout our rotation. And that being said, I want to give a big thank you to Dr. Wright. Please give him a hand of applause. The reason why I left Dr. Wright for last to thank is because he is the reason why both of us are here. Myself and Dr. Noba, we're here because Dr. Wright, as you all know, he's not just here at Butterfield caring for patients and teaching. He's also involved in the process of selecting the residents that come to this program, which is a very important role. And to be selected by somebody like him is a privilege. I remember the day that I got the news that I had been selected to come to this program. It was one of the best days of my life. I still remember I was in Ghana doing mission work when the news hit on email. And I just want you all to know that we are very grateful to Dr. Wright for the role that he plays in selecting the right people to come to this program, and most importantly, giving opportunity to people who otherwise would not have the opportunity. You know, there's a lot of talk about diversity, and I just want you all to know that he exercises that. That's the reason why we're here. So thank you, Dr. Wright, and I'll miss you. It's my last year. So I also want to thank my partner, Dr. Nwuba, for working with me in getting everything ready. He did most of the work, I have to admit. I did a little bit. He did most of the work. First, as it says, the big three in arthritis and other joint-related pains. Hopefully, the four that we talk about, you will leave here today with some information that can help you or that you can share with somebody else. The first thing I would like to do is please give us a few minutes to just introduce ourselves as far as our background, because I think it's important for you to know where we come from, and I'll try to make it short. I'm going to talk about Cameroon, which is where I was born and raised, and Dr. Nwuba is going to talk about Nigeria, which is where he was born and raised. What's interesting is that we're neighbors, and you can see right there Cameroon to the right. Right there is Cameroon, and I'm from somewhere right around here near the Atlantic coast, and Dr. Nwuba is from Nigeria, and he'll talk about Nigeria. So Cameroon, I tell people, the map of Africa is like a black eye pea, and this is the black eye, and we're right there. So we're kind of central west, you know, we refer to regional-wise Central West Africa, and it just has a very interesting shape. I love our map. Cameroon has about 27 million people. It's got over 250 native languages. French and English are used as international languages in order to allow the population to communicate. Because with 250 different ethnic groups and languages, we would not be able to speak to each other. I mean, my husband and I don't even come from the same region. So thanks to English, we're able to communicate. In 1884, Cameroon became a German colony, and it was spelled Kamerun, so Cameroon. And then post World War One, as you all know, France took a beating in World War One, and so Cameroon was the last colony to be divided, the last German colony to be partitioned according to the League of Nations mandates. And so Cameroon was divided between France and Britain. But interesting, because Britain said, hey, we're just going to take the small section right here, which is southern Cameroon, which is where I'm from. And they're like, France had such a beating in the World War that it'll give France the rest of the country. Well, we later find out the reason why the Brits did that is because there's oil over here. So they took the oil-rich section. So in 1960, Cameroon, the French-speaking part of Cameroon, gained independence from France, and it was led by a gentleman called Amadou Ahidjo, whom I got to meet when I was a little girl. In 1961, the English-speaking part of Cameroon got independence from Britain. And that part of the country was led by my grandfather's brother, who was also a physician. His name was Emmanuel Endely. He's of late. And then in 1961, the French and English sections of Cameroon merged into the Federal Republic of Cameroon. The English-speaking part used to be governed together with Nigeria. So that is the reason why Dr. Nawuba and I have so much in common. We actually speak a language called Pidgin English. A lot of people in Cameroon went to Nigeria for further studies. So that's the reason why Cameroon and Nigeria have that connection. And so the main thing that Cameroon exports is oil, cocoa, and coffee. And here's another map that just tells you how close the two countries are. And then here is Nigeria, and that's Abuja. He'll talk about Nigeria. Oops. And this is just a picture of the heads of states currently in both countries. That's my president right here, President Paul Biya, and I just want you to note that he's the oldest serving president. He's currently 90 years old, going on 91, and he's been in power since, I think, 1984, and that's his very young wife. I'm going to go ahead and give Dr. Naoba time to quickly talk about Nigeria before we go into osteoarthritis.
Good afternoon, everybody. My name is Kingsley Naoba, and like Dr. Mamois has said, Nigeria and Cameroon share boundaries. But the interesting thing about Nigeria is the fact that we are the largest black populace in the face of the earth. So most black people actually come from Nigeria. Most of the black people you see in the world have origins or ties to Nigeria. Nigeria also is nicknamed the Heart of Africa. If we go back to the map where it shows the map of Africa, you could see the location where it is placed. So it is nicknamed the Heart of Africa. Our biggest export is crude oil, and that was one of the reasons the British colonized us. We're colonized by the British. So we speak British English in Nigeria, although we have a local, like, broken form of English which is used in the general population. It's called Pidgin English. It's more or less like a vernacular form of English, which is not, which doesn't have like all the tenses and consonants and stuff associated with it. We have over 213 million people living in Nigeria, and we have over 500 languages. So just imagine how confusing it can be. However, English is the general means of communication for everybody. So irrespective of where you're from, if you're able to speak English, you're able to understand each other. Abuja which you see in the picture, happens to be the capital city of Nigeria. This is where the seat of government is. However, one of the largest cities of Nigeria, which I believe some people in this room might have heard of, is called Lagos. That's like where that's like the New York of Nigeria, where you have all the business offices, all the headquarters, all the organizations. That's where they are domiciled. Aside that, one of the strongest things Nigeria has been enjoying in the last few years is democracy. So, as expected in a lot of African countries, we've had military rule, which is not fun because under military regime, you do not have like the right to say what you want. It's more like you are under like a dictator. But for the last 20 years, we've had a democracy where we elect our presidents. Although it's not free and fair, but we at least get the opportunity of getting a president. So that's the current president of Nigeria. His name is Muhammadu Buhari. He's actually supposed to be leaving office on the 29th of this month, and the other elected president is supposed to be coming in on that same date. That's his wife next to him, obviously. That aside, one of the biggest exports we have is crude oil. Nigeria is one of the few countries that have the highest amount of crude oil, and that's where a lot of our foreign exchange comes from. It has been a blessing and it has also been a curse. It's a long story, but I will not go into it today. And then I think that's about it for Nigeria, and I will let Dr. Andela go ahead and start telling us about her presentation on osteoarthritis. Thank you.
Thank you. All right, so osteoarthritis, what is it? I think it's really important that if you leave here today, we would really like if you know the difference between osteoarthritis and rheumatoid arthritis. That's one of our big goals because a lot of people mix the two up. So in the case of osteoarthritis, degeneration of the cartilage and damage to the bone below, synovial membrane damage, ligament damage, and muscle damage. It is the most common arthritis, and it's non-inflammatory in nature. So you're not going to have the redness, the heat, and all of that that comes with an inflammatory type of arthritis. People affected 55 to 74 years, begins later than most inflammatory arthritis. And so we're looking at over 40 years, and 70% of it occurs in your hands, 40% in your feet, 20% in your knees, 3% in your hips. And one of the things that Dr. Wright wants to make sure I mention is that you also get it in your spine, cervical and lumbar spine. And it's more prevalent in women. So aging affects it. So the more birthdays you have, you're at risk. Being a woman, the kind of genes that your parents handed to you. Also mechanical forces, some kind of an accident you've had in the past could be a risk factor, your nutrition, and most important of recent is being overweight. Now in the Western world, it's very obvious that we do have a problem with maintaining a healthy body weight. So we're gonna see a lot more of that because of the Western diet. As far as the distribution, I would also like you folks to take a look at this picture because these particular joints of the hands are involved. And to make it easy for you, we just use the letters. You know, this is D is for distal, proximal, metacarpal, and then this, and then CML. So just so you know, we don't want to bug you with the big terms, but just so you know that when you're looking at somebody's fingers, there are particular joints that this disease affects. And then one of the things that you would see, not everybody has these, but there's something called Haberdin's nodes, which occur in some of those joints, something called Bouchard's nodes. We hear crepitus, there's problems with range of motion, and then a lot of people have bunions as well. And as far as inflammation, not so much like you have in rheumatoid arthritis. So what do we do if your doctor does x-rays and does some clinical studies on you and tells you that you have arthritis? It's not the end of the world. Just like every other condition, there are ways to manage it. But I want you to know that as a patient, you also have a role to play in managing this condition. So it's not just the doctor ordering medications or things for you to do. You have to buy into the disease, buy into why it's occurring and how to manage it, because it is painful. We manage this in a stepwise manner. So the day you get your diagnosis, you're not going to go into surgery the next week. We really start very simple with things that don't involve medications. So just like what we're doing today, we educate patients about osteoarthritis, what joints are affected, why we have it. That's really important. Also, the importance of weight loss. We want to have people have a BMI of less than 25. I've not been able to do that myself, but it would be ideal to have a BMI less than 25. Physical therapy and occupational therapy, which are provided at Butterfield, available to patients. Aerobic exercises, especially water aerobics. You folks do have a pool here, and I am sure that there's somebody who comes and works with people in the water. Using a cane, using a walker, using special shoes, all of those are ways to manage this without using medications. When the pain gets to a point where something has to be done because of the discomfort, Tylenol is definitely something that we like to use. It's a safe drug, unless somebody has liver problems or they drink heavily or they're on Coumadin, then that could be an issue. But otherwise, we really like to start patients off with Tylenol. Sometimes we even have it scheduled where every day they use it, maybe twice a day. And then there is another group of medications that we would go to next if the Tylenol isn't really doing it. Those are called non-steroidal anti-inflammatory drugs. Those drugs have side effects that we're concerned about, especially for people over 65. So we try to avoid them. However, there is a topical version of the non-steroidals, which is called Voltaren gel, which has become very popular. We really encourage use of that because the side effects are less, since it's a cream that you're actually applying. So I'm not sure how many of you are familiar with this. It's diclofenac or Voltaren, and it does good work. Other things like Celebrex, depending on how your kidneys are working, depending on whether you have stomach ulcers, we try to avoid those. But if you're using these, then that's a discussion between you and your doctor, saying that it's okay to use these. But the other thing with these non-steroidals is that we like for people to use them, if they're using it regularly, to use them on a full stomach. Have something to eat, at least, even if you don't have a full stomach, but crackers or something. So don't use Motrin or Advil or Meloxicam or Aleve without food. Here's a picture. These are seniors that are having a good time, having fun while exercising and getting some relief from arthritis. It is one of the highly recommended exercises for arthritis. So you can have this here in your facility. Some local gyms have programs. You can also have YouTube videos where you can review the different techniques or the different exercises you can perform in the water if you're one of those people who likes to exercise by yourself. Doesn't have to be in a group. So when things get really bad, we start looking at steroid injections. We start looking at injecting something called hyaluronic acid. We look at surgery, joint replacements, send you to an orthopedic physician. And then we look at more potent drugs like opiates. Tramadol's pretty good, and even duloxetine. So as just from what we've talked about, it's kind of a stepwise approach. When you're diagnosed, we don't immediately say, oh, you need a knee replacement or you need injections. We start low and do things without medications and then finally get to a point where you could end up having surgery. Weight loss definitely is key, and there are some people who've really made a difference having weight loss. So I will have Dr. Nauba come and talk to you about the other arthritis. Thank you.
So the other arthritis we'll be talking about today is rheumatoid arthritis. I kind of think about rheumatoid arthritis as like the sister of osteoarthritis. Well, rheumatoid arthritis itself is due to an inflammatory process. Basically, what that means is your body is attacking itself. It occurs when you have inflammatory agents, they go into the joints and they start attacking the cartilage, the synovium, and different membranes that make up those areas that help protect the bones from rubbing against each other. What this does is it creates an inflammatory process where there's a swelling up of those cushion that is supposed to protect the two bones from rubbing against each other, making it look unhealthy, making it look rough, and making it look making the joint space to become widened. So this was what I was talking about. From this image, you can see here, this is a healthy bone. This is a healthy cartilage with the synovial fluid in there and synovial membrane. However, this is an unhealthy or rheumatoid arthritis joint. As you can see, there's a thickening of the synovium between the two bones, and this is called pannus. That's the medical name for it. And then there's extensive cartilage destruction. So think about the cartilage as a cushion that protects the two bones from each other. So what the inflammatory agents go in and do is they destroy this cartilage and make it unavailable to provide that cushioning effect between the two bones. So there are some risk factors that could predispose you to rheumatoid arthritis. One of them could be idiopathic, which means it's non-specific. Some of them are spontaneous. Some people are just unlucky and they just have rheumatoid arthritis. Another risk factor could be positive family history. Some of the cases are genetic. If someone in your family has it, there's a chance you might get it. And this is also related to like the inheritance pattern of it. Smoking is another factor that can predispose you to rheumatoid arthritis. Bacterial and fungal infection, it happens, but it's not as common as these other factors mentioned earlier. So the most important factors to consider for rheumatoid arthritis are the family history, the smoking, and sometimes it could just be spontaneous. It could be due to any reason, so it could be idiopathic. So what are the incidences of rheumatoid arthritis in the US? So it's a disease we see in between 0.5 to 1.0% of the population. So it's not pretty common as we would expect it to be. And the peak age, surprisingly, is in your middle ages, so from like 45 to 65. Although there are cases when it happens really, really early. In those cases, we call it juvenile rheumatoid arthritis. Well, sadly, 75% of these are women. It seems women are unlucky. So 75% of these cases are women, and in most cases we see that women are 3 times more likely to have rheumatoid arthritis as compared to their male counterparts. So this is taking a look at how rheumatoid arthritis affects the body. What I want you to pay attention is this diagram or this image right here. You can see it's symmetrical. What I mean by symmetrical is if it is happening in this wrist, or in this hand, it's going to happen in the other hand. So it happens bilaterally. So if it's happening in this lower extremity, it's going to happen in this same lower extremity. So you do not see cases typically where rheumatoid arthritis happens in one part of the body without happening in the other part of the body. And this is also what I had talked about earlier. You can see this side of the bone. This is just like showing you the normal and what the abnormal part looks like. So you can see this part of the bone. You have the synovial membrane, the cartilage looking pretty healthy, the synovial cavity looking pretty good. Now take a look at this part of the joint. You can see there's a lot of swelling and inflammation, and the cartilage itself is destroyed by those inflammatory agents. And this is more like a pictorial explanation of what I was talking about. So these factors you see here are different inflammatory factors which are in the body. Typically, they are supposed to help fight against foreign organisms or fight against bacteria, viruses, and stuff like that. However, in rheumatoid arthritis, instead of doing those fighting against the external agents, they fight against the body itself, causing you to have the inflammation which you see here. So this is just like the whole breakdown of the process of how it actually happens. And you can see it's resulting in cartilage degradation in this area. So I put up this picture for us to take a look at how the symptoms and how it occurs initially. So typically, the most common place where you see rheumatoid arthritis is in the hands. That's where it occurs typically, and that's where it typically starts. So what you notice most of the times is for patients that experience this, they tend to have tender, warm, and swollen joints, and they tend to have joint stiffness, which gets typically worse in the mornings and after inactivity. And then sometimes you get fatigue, you feel lethargic, you have fevers, and you have a multifactorial symptom associated. It could be lethargy, you could have loss of appetite, loss of weight, just feeling generally unwell. But typically the joints of the hands become stiff, they become swollen, they become tender. So this is what starts telling you that this might be rheumatoid arthritis, and it might be time to go see your doctor and get more information on what to do. So when you go see your doctor, typically, we want to do a diagnosis to find out if for sure you do have rheumatoid arthritis. And the first thing we typically do is imaging. And the first imaging we majorly do is the X-ray. So if you take a look at this X-ray, this is what an X-ray of the fingers actually look like. So this is a normal one, or early stage of rheumatoid arthritis, and this is terminal rheumatoid arthritis. So you can see in this area, this place right here, you can see how swollen and how swollen it actually looks compared to the joints right here. So it progressively gets swollen, it progressively gets edematous, it progressively gets irritated and painful as the rheumatoid arthritis progresses. Other imaging studies we could also do is the magnetic resonance imaging, which is also known as the MRI. And this is what an MRI looks like. We typically do not do the MRI. We usually do the X-rays first. But if we want to do further workup, we want to do further diagnosis, we can go ahead and get an MRI of the fingers or the extremities or the part of the body that has rheumatoid arthritis. And this is what an MRI looks like. So take a look at this place here. You can see the joint has a little bit of swelling in that aspect. So that's what I was calling the panus, the swelling, when you have the cartilage getting bigger due to the inflammation going on in there. So this is evidence of rheumatoid arthritis right here. This is another evidence right here. And if you take a look here, although this is not very much visible as compared to this, but you can see the joint here is really swollen. So aside the imaging, there are blood tests to check for rheumatoid arthritis. The two major ones are rheumatoid factor, which sometimes can be negative in the initial states of rheumatoid arthritis. However, when it's negative, it does not mean you do not have rheumatoid arthritis. You could have rheumatoid arthritis, but initially it could be negative. But typically, as the disease progresses, it usually comes back as positive. So typically, for when a patient comes to the clinic, if we want to do workup, we usually do the rheumatoid factor to check and confirm for rheumatoid arthritis. If it comes back positive or negative, we can go further and do more workup with the Anticitrullinated Protein antibodies. This is a confirmatory test for rheumatoid arthritis. If you test positive for this, you have rheumatoid arthritis. So if we test this, whether it comes back positive or negative, we definitely want to do this. And if you come back positive for this, you have rheumatoid arthritis for sure, 100%. So it has a specificity of 95%, and this high specificity in statistics makes it a good study for confirmation of rheumatoid arthritis. So there are several other blood tests that are also used to check for rheumatoid arthritis. These ones are not as good as the other two I had mentioned in the last slide. So the ESR is called the erythrocyte sedimentation rate. So basically, this test, it gets elevated. I think the normal should be 30, but when it gets above 30 for the ESR, you start getting concerned that there's an inflammatory process going on. So it's not really specific, but it could guide you to see that there's kind of like an inflammatory process going on. C-reactive protein is also similar to the ESR. When they are elevated, it tells you there's kind of an inflammatory process going on. The full blood count can be used, the renal function test, and the liver enzymes can also be used, but they are not as good as the tests I had mentioned in the previous slides. So I was going to show you guys the different stages of rheumatoid arthritis. Sometimes it's really hard to tell what stage a person is at. Like it progresses really fast for some patients, and in some patients it takes years and years to get to the really bad stage. So when you have a patient, this is what the normal joint looks like. You can see the synovial membrane, you can see the bone, you can see the cartilage looks pretty healthy. When this gets to stage 1, the antibodies are already eating away at the cartilage, inflammation is going on. It progresses to stage 2, the cartilage are almost gone. You typically don't even have much cartilage left. There's still inflammation. By stage 3, you start having some kind of fibrosis. At this point, the bones are just like stiff. They're not moving anymore. The patient typically is in a lot of pain. The bone is not moving. The joint is almost like they can't use it anymore. And then by stage 4, which is the last stage here, the bone actually fuses. So at that point, it's like there's no joint at that particular location. The joints are stiff. It's more like the patient is pretty much disabled at this point because those joints cannot bend, they cannot move, they're just stiff and frozen in place. So there are a lot of medical treatments for medical management for rheumatoid arthritis. Typically, the first line we usually go for is the NSAIDs. NSAIDs involve, these are medications like aspirin, ibuprofen, and stuff like that. The good part of the NSAID is that it helps with the pain, it helps with reducing inflammation. That's what the NSAIDs typically do, they reduce the amount of inflammation you have. But the bad part of the NSAID is the fact that it can affect your kidneys. They are not good for the kidneys on the long run. And they can also result in issues with your GI system. So they go out and cause the lining that coats your stomach, that protects you from the stomach acid, gets eaten away by the NSAID. So it can cause you to have abdominal ulcers and stuff like that. So typically we try as much as possible not to put patients on NSAIDs for a long time. Steroids is something else we use to manage rheumatoid arthritis. Now the thing about steroids is, steroids typically we only use it for a short time because it has a lot of side effects. Patients typically tell me that it makes them feel good, but if you stay on it for a long time, you start having a lot of changes to your hormones, and it makes a lot of changes to, like, you start having elevated blood sugar, elevated white blood count, you can start having fat redistribution and stuff like that. And steroids, typically, we only use it for short terms. So we use it for when patients have severe flare, like when they have severe exacerbation of rheumatoid arthritis. So we use it for a short time, and then we try to take the patients off the steroids. Next one we have is the DMARDs. It sounds like a big medical name, but it's not a big medical name. DMARDs actually stands for disease-modifying anti-rheumatic drugs. So there are several of them. So there's the common DMARDs. I believe a lot of us in this room have heard of methotrexate. So these are typically medications that help with, that fight against inflammation. So there are several of them. There's a long list of them. So it depends on what your physician, your primary care physician, typically your rheumatologist thinks is best for you. So, but methotrexate is the most common one, and it helps to reduce the inflammation and progression of the rheumatoid arthritis. I believe if you've watched a lot of TV recently, you probably would have seen these Xargans or Rinvoq and stuff like that. It's on the TV ads. So these are newer medications that also help with rheumatoid arthritis. Each medication here is good. I believe a lot of us probably would have also seen Humira on TV. It's on the ads these days. So they are all good and they work in different ways. We're not going to go into the way they work. They have different mechanisms of action, but they typically work to help reduce the progression of the inflammation and reduce the pain and reduce the progression of disease for rheumatoid arthritis. So it's going to be up to your rheumatologist or your primary care physician to figure out which one is best for you, because every patient is different, and decide which of the DMARDs is best for you to be placed on. So aside the medication management, when rheumatoid arthritis gets really, really bad, we can do various surgical procedures to manage it also. One of them is arthroplasty, which is basically like replacement of that joint. The most common joint we typically do this for is for the knee replacements or the knee arthroplasty or the hip arthroplasty. For the fingers, the option to do that is very limited. So typically we don't do replacement of joints for the fingers. It's mostly for the hip and for the knee. The other option we could do is arthroscopy, which is more like putting a light instrument in there to kind of like remove the debris as much as possible. We also have carpal tunnel release. So if you have rheumatoid arthritis in the wrist, your surgeon could go there and try to release the tension due to the inflammation from your wrist. Spinal fusion is something that is done by the surgeon, and typically these procedures are typically not just done as first line. They are done when the patient is in severe pain, when the rheumatoid arthritis is not getting any better. That's when the surgeon typically steps in to get these procedures done. And the last one on the list there is synovectomy. Basically is to remove that inflamed tissue and just as much as possible probably replace the joint or try to do some kind of fusion of that joint. If you see on the last part of this slide, I said physical therapy is also important. So that's something else that we as physicians believe that really does help with rheumatoid arthritis. Basically, the way I see it is if you don't use it, it gets redundant. So basically, we want you as much as possible to keep using those joints, as much as possible to keep them from getting fibrosed. So physical therapy comes in play. It's a very important part of managing rheumatoid arthritis. That's why a lot of time when patient comes with this pain to the hospital or to the clinic, we try to refer them to the physical therapist to help them with exercises for those joints to keep it moving. So that brings us to the next topic, which is known as gout. Gout is really popular because of the kind of food we eat here in the US, the meat, the crabs, the seafood, the drink. Everybody likes good food. Everybody likes a steak. But sometimes some of us are unlucky to get gout, so we're going to talk about it. So what do we know about gout? So think about gout as an accumulation of crystals in a particular joint. And these crystals are called monosodium urate crystals, right up here. And they usually typically accumulate in a particular joint. It could be in the knee, it could be in the great toe, it could be in the elbows. Patients get it differently. It just depends on where it's not specific, but it can accumulate in any of those joints. So the thing about gout, this is a fancy table that just shows how the various things work. I'm going to try to explain it break it down as much as possible, as Dr. Wright had suggested. Basically, what happens here is the normal metabolism in the body basically leads to uric acid being formed, right? And this uric acid is broken down and is excreted in urine, in pee, in your feces. What happens in gout is some patients are so unlucky that they form a lot of uric acid that they cannot excrete. They are not able to excrete all the uric acid in time from the urine or from the pee. And when you're not able to excrete all those uric acid formed, what happens is they go to those joints and they build up. So let's think about it this way. Gout is a kind of disease that forms when you have the excess of those uric acids, right? So two things can kind of push gouts to form. When you consume those foods that are high in uric acid, like the meat, the crab legs, or the steak, or whatever you're eating that has the high uric acid, a lot of uric acid is formed. your body is not able to excrete all of it in time, and then the crystals from those uric acid accumulates in the joint, causing you to have that gouty arthritis. In the other scenario, if you are taking any medication that is competing with the excretion of uric acid from the body, let's say you're taking any medication that goes through the same channel that uric acid is supposed to be removed from the body, the uric acid is not going to be removed as much as possible because something else is competing with it. What happens in that scenario is the uric acid that is not able to be excreted from the body backs up and goes and accumulates in the joint, causing you to have the gouty arthritis. So I was talking about the food that causes the gout. Common causes of the gout are the intake of food that has high protein, because those food have high purine, and this purine is what breaks down into the monosodium urate crystals. Some of us are unlucky because our GI system is not as good as it's supposed to be. So when we eat, sometimes it's usually genetic. So when we eat some kind of food, instead of being absorbed properly, it goes through the GI system and forms the monosodium urate crystals. And this is what I was talking about, like medication like aspirin, some kind of diuretics. When you talk about diuretics, you talk about like Lasix, those kind of medication. What they do is they compete with the excretion of they compete with the excretion of what do you call that stuff? They compete with the excretion of hold on, let me go back to. They compete with the excretion of uric acid from the kidneys, and if uric acid is being competed, imagine two people are trying to run through that door, as opposed to one person running through that door. So if uric acid is struggling to go out of the door, and aspirin or the diuretic is also struggling to go through that door, what happens is the uric acid backs up and causes you to have the gouty flare. So these are some of the causes. One of them is the food, some of them is the digestive system, and then the other cause could be you taking medication that competes with excretion of the uric acid. So this brings up this slide actually shows you the various symptoms of gout. So if you've had gout before, you know it's very painful. Your joint is swollen, and sometimes it shows like it's reddened. It looks abnormal in a way. So what happens is these crystals, when they are not able to be excreted from the body, they go to a particular joint, they back up and cause you to have, because it's not supposed to be there. So when it accumulates in that joint, it causes you to have pain and tenderness in that area, which causes you to have the symptoms you get. Okay. So these are the symptoms I was talking about. As you can see in this patient, he or she had gout in the big toe, which is the most common location for the accumulation of the monosodium urate crystals. You could have it in the ankles, you can have it in the knee, and you could even have it in the elbows, as you can see in this patient. So it deposits in any of the joints. It's not specific. And the interesting thing about gout is if you've ever had it in the past before, you will always have it. Like it doesn't mean it will come back today or tomorrow, but there's a possibility that you will definitely have it again in the future. It's just a matter of time. So here are the risk factors for gout. We've already talked about that eating protein-rich food and a high alcohol intake can cause you to have gout. This especially includes like beer, and this protein-rich food includes like the steak, the crab legs, like I talked about, and a lot of those really juicy food most of us like to eat are very high in protein. So these are usually like one of the main risk factors for gout. Certain races, like these are mostly like the islanders, they are very much predisposed to having gout. Obesity is another cause of gout. High cell turnover, and these refer to patients that have cancer, patients undergoing chemotherapy. Basically what happens is when you're undergoing chemotherapy, a lot of the cells are dying, which creates, and those cells that are dying need to be excreted from the kidneys. So the kidneys are already overworking themselves trying to excrete those cells that are dying, and in such a way they are not able to excrete the uric acid, which backs up and causes the patients to have gout. Some drugs, like I had talked about, like the Lasix, they cause you to have gout because they also compete with excretion of uric acid from the kidneys. And as expected, patients that have kidney diseases are also predisposed to gout because the kidneys are not able to put out the uric acid as expected. So that could be another reason why those patients have gout. So typically this is like the history of how it presents. You see the patient comes to the clinic and they will tell you, oh, I went out to a party yesterday, I drank 3 bottles of beer, and the next day they have these symptoms, which could be the sudden swelling and redness of usually the great toe or any of the other joints. So typically the patients that present most of the times in a lot of the cases probably had maybe a good sumptuous dinner the night before or the day before, and then come into the clinic and with these symptoms that are listed in this slide. So how do we diagnose gout? So we distinguish them into two types. The acute ones, which is the most common ones, with the patient coming in typically after maybe consuming a lot of food that are high in those crystals, or that usually result in uric acid crystals. Or some patients have chronic gout. So typically those patients, irrespective of what they eat, they usually have those gouty arthritis symptoms. So how do we diagnose it? The first thing we do is physical examination. We take a look at that joint. We look at how swollen it is, how tender it is. It could be anything. Something else we also do is we do like an aspiration of the joint. So there's something called positively birefringent crystals. I know it sounds like a big medical term, but it's not. It's basically like looking at the crystals under the microscope. If they have a certain color, it tells you that this crystal is actually a monosodium urate crystal, which is a cause of the gout you're having. So like I was saying, this is what I was talking about when I talk about aspirating the fluid and looking under the microscope, and you see a uric acid crystal when you look at it. We do a blood test where you check for the level of uric acid in the blood, and it's pretty elevated. And we can also do an X-ray in some cases where we can see that an accumulation of the uric acid crystals in the joints too. So these are some of the ways we diagnose gouts typically in the clinic or in the hospital. So the treatment for gout, typically we divide it also into 2 parts. For the acute gout, we can give NSAIDs, such as like aspirin, ibuprofen, meloxicam, to manage the pain. It actually does help to ease away the monosodium urate crystals and ease away the pain. Colchicine is another medication we give for gout. It's an interesting medication. It has an interesting mechanism of action. I'm not going to go into it today because it's a little bit complicated medically, but it actually helps with reducing the acute gout flare. And then we also encourage patients to rest the joint. We already have the crystals in there. We don't want you to go squeezing the joint or pressing it or trying to pinch it or scrape it. So we encourage patients not to rest the affected area. Now, the other interesting thing we do for patients that have acute gout is we give steroids, but this is typically reserved for patients that have renal disease. Remember I told you guys that NSAIDs actually have side effects on the kidneys, and colchicine also has side effects on the kidneys. So if a patient already has kidney disease, we don't want to give them any of this medication. We just go for steroids. So we can do steroid injection into the joints to help with management of acute gout in these patients with renal disease. So for patients that have gout on the long run, typically what we try to do is we have 2 ways of handling it. We give a medication called allopurinol. It's the most common one. There's another one called febuxostat, but allopurinol is the most common one we give. What it does basically is it limits the amount of uric acid formed by the body. So there's a pathway that forms uric acid. Allopurinol blocks one of the enzymes called xanthine oxidase and prevents uric acid from being formed. So if uric acid is not formed, there's no chance that there will be an accumulation of the crystals that cause the gouty arthritis symptoms. The other thing we do is we also give a medication called Probenecid, that's another option we do. It helps the kidney excrete these gouts, these uric acid crystals. So if it's being excreted really, really fast, it's not going to accumulate. So the patients will not have those gouty symptoms. So typically we tell patients that have chronic gout symptoms to take this medication daily for management of their issues. So how do we prevent it? I believe everybody in this room already have an idea of how to prevent gout. Basically, you try to avoid those foods that are high in protein. You try to avoid them because if you eat them, that's where you have those crystals coming from when they are degraded. You try as much as possible to stay hydrated, take a lot of fluid, even if it's hot outside. I know we sweat when we walk when it's hot. Try as much as possible to stay hydrated. Avoid anything that causes strenuous exercises. Now, I know exercise is good. Even if you're going to do strenuous exercise, make sure you're taking a lot of fluid, because if you stay hydrated, it's more like you're flushing it out as much as possible. So even if you're doing a strenuous exercise, you're going to sweat, but make sure as much as possible you're taking a lot of fluid. And then for patients who are already taking diuretics, we always advise you to be careful. So if you're having these symptoms, you can meet with your primary care physician and review the medication you're taking so that we could see which of these medications are working against, which of these medications are causing you to have these gouty symptoms. So we could either lower the dose or find an alternative to prevent you from having this gouty arthritis. So these are some of the complications of gout. Typically, we try as much as possible to avoid that our patients get to this level. This is when you do not take care of yourself, you're not taking your medication, or you're not managing it appropriately. So as you can see in this situation, this patient has joint damage because they've had chronic accumulation of those monosodium urate crystals. So probably they were maybe not taking their medication or not being followed by a physician. This is when you have the monosodium urate crystals from uric acid accumulating in the elbows. In a lot of cases, when it gets really bad, these patients it gets so bad they're not able to have a full range of motion. So this could have easily been controlled by taking the right medication. But I guess it wasn't well managed, so it got to this complication. And this is also known as a tophi, or a gout tophi. So basically, it's an accumulation of those monosodium urate crystals in the great toe, which is the most common area where the crystals accumulate. And also, on the long run, if you don't manage it properly, it could also lead to the damage of your kidneys because it stresses out the kidney in the process, and in the long run could lead to them failing. So in as much as patients do get gout symptoms, we want them to be well managed. So if you have these symptoms, definitely want you to be on medication and want you to monitor what you eat, what you drink, to help with controlling you from getting the complications associated with gout. I think that's about it. Thank you.
Thank you, Dr. Nauba. I am ending with PseudoGout, which is not as common as gout is, but they are treated pretty much the same way. The crystals here, I guess today we're talking about crystals in people's body, I guess. So the crystals here are called calcium pyrophosphate crystals. And so just a little bit of information about pseudogout. First of all, it affects the big joints as opposed to regular gout, which he just talked about. So your knee, your wrists, your ankles, and it's caused by different things. So it's not like what he talked about with well, we have alcohol as something in common, but it has nothing to do with uric acid. So trauma, illness, fasting, having an infection, all of that can cause this acute inflammatory kind of arthritis, which we see, which occurs in people over 60. And so you end up with pain, redness, and swelling, and it could occur again, but it's not something that's chronic. It just flares up. And so just like he talked about getting the fluid out of the knees and examining it under a microscope, you have a different type of crystal as opposed to gout. This one is more of a rhomboid-shaped, positively birefringent crystal. So that's how doctors know the difference between both. Here you see a healthy joint, and then here you see PseudoGout, where you have the calcium pyrophosphate crystals. And we manage it pretty much like we do with gout. First of all, you treat the underlying cause. If it was an infection, if you treat that infection, it should get rid of the symptoms. We also use NSAIDs. We also use steroids that people can take orally or that we can inject into the joint. And if you have over 2 attacks a year, we could end up putting you on colchicine twice a day or NSAIDs. And make sure we protect your lining of your stomach because of what we talked about with NSAIDs and the side effects. And then sometimes we will use hydroxychloroquine. Remember that drug from the COVID days? And we could also use methotrexate. So these are the references that we both use to prepare to give this talk today. And we want to thank all of you for coming. We want to thank Dr. Wright for all of his teaching and for us being here. And we would like to now give you folks the opportunity to ask questions.
We'll go out. Someone raise a hand and take a, here's one right off. I think that's working.
There's another kind of arthritis I've heard about, and I've actually seen it. It kind of looks like gout, but it isn't. It's called palindromic arthritis. Do you know, how does that differ from osteoarthritis and rheumatoid and gout?
Who can speak to that?
So, interestingly, I've not heard about palindromic. I do have heard about psoriatic arthritis. Is that in any way related?
You stumped the stars here.
Thanks for the question. We'll look into it.
You stumped us.
So every medication has side effects, but her question basically is there any side effect from taking allopurinol for a long time? So I was saying every medication has side effects, but typically we put patients on doses of allopurinol that do not have as much pronounced side effects that would be concerning. So unless it starts giving you symptoms that are overt, that are noticeable and concerning, we typically think it's safe to take it for a long time. So
I know some of the common side effects, you can have a rash, you could have diarrhea, you could have nausea, and then it could also affect your liver enzymes. But again, if you look at the inserts, when it comes to medications, they all have long lists. So allopurinol is generally safe.
Yeah, I'd say allopurinol, most people are able to take it even for decades without side effects. It's, after you've had one pretty certain bout of gout, the doctor diagnoses it as gout, you're probably going to have a second one. We sometimes wait for a second one because there's some people who will be 5 years before they have another bout. But by the second bout of certain gout, we put people on allopurinol because it will prevent it. Most people, once they get on allopurinol, at least in the right dose, they just don't have any more attacks. And they so many deformed joints that he was showing, we don't see much anymore because this medicine works so well. That's a good thing. Yes.
Well, my question is really, my sister has arthritis so bad she can no longer close her hand and she can't open jars, and she's taking steroids now, and on the overhead, it said you couldn't take them for a real long time. What then would be her next step?
And does she have rheumatoid arthritis? What you described is more common with, with rheumatoid. So it would be a different answer for a different, if it was osteoarthritis, but probably it's rheumatoid arthritis. And back a few decades ago, earlier in my career, we basically had aspirin and we had prednisone or steroids. And if you're on steroids for a long time, there are just a lot of side effects. But these other medicines they were listing, especially the newer ones you see on TV all the time, the biologics like Humira, and there are 5 or 6 others that are on his list. Not every one of them work for every person, but most people will respond to one of them, and it makes a big difference. So got a lot more effective medications now than we used to. So,
If I may, I just wanted to add that as far as your loved one and the changes in their hands that's affecting what they're doing every day, it's really important to work in collaboration with the therapists, because there are different devices that they can give her to help with, handling cans or doing certain things and certain exercises that she could, be taught how to do to prevent things from getting so stiff where she ends up with contractures.
really good point. And physical therapy, as you would imagine, but also occupational therapy. They just are very creative with ways to prevent that.
Somebody had a question here. Is it you? Okay.
Yes, I sort of have a practical question, and it's this. I'm referring to the osteoarthritis that does not involve inflammation. And I believe that it's true that it's mainly a wear and tear kind of effect, that after long years of use in the older population, then they begin to have trouble with their joints. Now, here's my question. If that's true, why is it that they tell you that the best way to handle that is to continue to exercise? If you have arthritis in the knee, then you're supposed to keep walking, and yet it's a wear and tear arthritis. That's my first question.
Well, ideally, it's keep exercising with non-weight bearing exercise. So the person with knees, with bone on bone in the knees, walking at certain stages can still be okay, but if you overdo it or at later stages, it's going to be the weight bearing. So bicycles are at least non-weight bearing. Things like that, swimming is ideal, or water aerobics. Good question. Another legitimate name for osteoarthritis, and it used to be the predominant name, was degenerative arthritis. So it's non-inflammatory degenerative arthritis.
And thank you so much, Dr. Wright. But I just want to add that because movement is so important, it is key that we don't limit movement because of a certain illness. So what he just talked about was modifying your type of exercise. So if you were a marathon runner, maybe we can get to a point where you may just do the stationary bike, or you may do more swimming than you did in the past. So it's all about understanding what arthritis is about and adjusting to what stage you're at. So activity is always a good thing. My dad has arthritis, and for years, he ran 5 to 6 miles daily. Now we have to put a brace on his right knee, and then I now can outrun him, which I have a lot of fun doing that, because I'm like, hey, I'm gonna leave you behind, and he's like struggling with his arthritis in his knee, but he hasn't stopped running. We just use different things to try to help him with a little cushion, but.
Well, maybe this question is going to be a little far out, but I need to ask it. I'm following with great interest the new research on longevity and the anticipation that in the future it will not be extraordinary at all for most people to live to be 100 or maybe 120 or 150. Of course, that kind of thing is not going to help our generation, but it is something that you doctors may see happen. And so I'm wondering if you are aware of some of this research and what it means then for the longevity, with the idea that it's going to be quality of life. In other words, all of these old age diseases, chronic diseases we're talking about, will be put off or at least delayed for a very long time.
I think I'm going to leave that one to Dr. Wright.
Now, it's a fascinating question, Helen. All of yours are. But, you know, it for along the way, as they're developing the things that we all know the visionaries are projecting that'll extend our lives along the way, it's gonna heighten the some of the even ethical issues, but certainly questions of, you know, do I want to be kept alive just to suffer longer? You know, so. But I think ultimately, I think some of these remedies, some of these incredible drugs that we're going to benefit from, in many ways, are, you know, really are going to be extraordinarily therapeutic. And living so that I guess we have to have kind of a faith in science too, that it's not just going to make us live longer, it's going to improve the quality of life that you're talking about. So
My question is, does stenosis have anything to do with what we are talking here now?
yeah, you're probably talking about spinal stenosis.
Yes, spinal stenosis.
So stenosis
Yes.
is a word that means narrowing
Yes.
of a normal channel, or and in the case of the spine, it's a spinal column, the opening through which the spinal cord goes, and the nerves leave at every level to go to the rest of the body. Spinal stenosis is often the biggest cause of spinal stenosis is arthritis. You know, one of the things she mentioned is the things going on with arthritis, and it varies from joint to joint which predominates, but there's the loss of cartilage, the cushion between the bones, and there's an overgrowth of bone. So that's why we talk about spurs and things like that in arthritis. And that bony overgrowth often in the spine is narrowing down things and starting to pinch nerves, and it's a very difficult thing to treat, but yeah, it is connected. We didn't talk about arthritis involving the spine, but most often in the spine, what you hear, the name that labels it in the spine is spondylosis, specifically degenerative spondylosis. And spondylosis typically means a combination of degenerative disc disease, same thing that causes herniated disc, degenerative disc disease where the disc between the vertebra dries up and becomes harder and narrower. That's why we lose some height with age. And then arthritis, which causes all this bony overgrowth. It's really common in the neck and the low back, for sure. So, yes, that's a long answer for yes. It does involve that. I don't either. I don't either.
Any more questions?
Great
Anybody else?
questions. Uh-huh.
Again, I'm referring to a treatment that you mentioned a lot of times, but particularly in connection with the non-inflammatory osteoarthritis. When you inject a steroid into a joint that relieves pain, what's the mode of action there?
I've thought and wondered this too, Helen. There is some inflammation in very arthritic, osteoarthritic joints. There's some. It's just not. That's not the because by the time these bones are rubbing together and everything, it'll create. So, and you can. She didn't mention it, and it's rare enough that it's not a big teaching point. But there is something called an osteoarthritic flare, where you can get a joint that only has osteoarthritis in it, but it flares up with inflammation periodically for a limited period of time, and that's when the steroids really help. Well, that's more like a bursitis, but yeah, it's inflammation there, and in the knee. I mean, most of it is cartilage is gone and bones rubbing together, or at least the patches of where there's no cartilage rubbing together, and there's some inflammation there. It is remarkable sometimes how dramatic the relief with a steroid injection will be for an osteoarthritic joint. So, good, really good point. Yes. I'll let y'all take.
Well, not really. Yeah, because that's more of a structural thing. But remember, we talked in my slides, I talked about some kind of trauma. When you have scoliosis, because there's a distortion in the way the spine is, it does put pressure on that. So yes, you could have arthritis of the spine related to the scoliosis.
Related to so many years of angulation and asymmetrical pressure on one side of the spine where the curve is. So it is true, if you live long enough with spondylosis, most people get a lot of back pain that they didn't have earlier in life, but it's when arthritis sets in that you usually start having the pain.
I actually just saw somebody in clinic with that scoliosis that led to arthritis in their spine. I just saw that, I think, this week or last week. And I also had a patient in the VA who had both osteoarthritis and rheumatoid arthritis at the same time.
So scoliosis has nothing to do with arthritis originally, but later on it'll result in it from the altered pressures at every angle where the bones are touching.
Any more questions? Any
Good-
questions
good
about Africa?
questions.
Do you have any questions about Nigeria and Cameroon?
My question is, if you are all done with your exams and your certificates and what have you, will you go back to your country?
That's a very fair question. I get that all the time. So it depends on the situation in our country. Mine is currently at war. So Cameroon has been at war since 2016. So there is a certain level of danger with packing up my whole family and moving there. However, every 3 years I go back home to visit family, and I'm also hoping that after finishing residency that I will be of use to the community as a healthcare provider, mostly through volunteer work. And our plan for our family is that I will eventually, once our youngest child goes to college, that I'll eventually move the family back to Cameroon. But it depends on the political situation. I'll let Dr. Noba answer for Nigeria.
Dr. Andala is too modest to tell you, but she's not just from Cameroon. She is from Cameroon royalty. Her family is royalty in Cameroon.
Dr. Wright likes to bring this up.
Wonderful book that her uncle has written, and much of it about with their family. And she's told me the name to look for. Anytime you see the name Indali, that's royalty, and that's my family.
Yes, apparently my great-grandfather beheaded a German And so he's
Oh.
also in the books for having fought in a very important war, fighting for freedom. Because, of course, in the case of Africa, we had a lot of colonialism going on, and a lot of times you had to fight for freedom. And so some families were key in that. So we are in several books because of that particular battle. But my family has been the royal family for our tribe for over 100 years.
So, did that act of desperation, you said beheaded someone?
Beheaded a German general.
So did that make him a hero, or did that put him in jail?
So he was killed.
Oh, gosh.
He was killed by officials, but he became a martyr.
Yeah.
Yeah.
Wow.
Okay. So I feel like the main reason why I decided to pursue medicine is the opportunity to give back to the society. And it's been my mindset that when residency is done, definitely I want to be in a position to go back home and impart the knowledge I've gotten from the US in my local community. So going back home is definitely something I really consider strongly. So definitely.
I also want to mention that we have student loans that we have to pay. And so dollars, it is easier to work and pay back your loans in dollars as opposed to currency like the francs, which I'll have to have a whole bags and bags of money to be able to pay my student loan if I was working in Cameroon. So the plan also is to give back to the US what was given to us to allow us to go to school, pay that back before leaving the country. So if we were to leave without paying our student loans, they actually come and arrest us. Like, they'll come find us.
So this remarkable lady, I'll just tell you, she graduated medical school at the University of Kansas, one of the really outstanding state medical or health sciences center. And she was a nurse before she was a doctor. And she became a nurse case manager for the University of Kansas before she went to medical school, and was, we were told, one of the most revered and popular case managers at KU. And now that we've worked with her, we know why. So,
Thank you, Dr. Wright.
anything else? Thank you so much.
Thank
your
you.
coming.
Thank you.
Thanks. We appreciate